milliliter concentration of CBD, and you can still, the dark blue spots are still viable cancer cells, but when the dose was increased from 15 micrograms per milliliter to 20 micrograms per milliliter, there was further killing of those neuroblastoma cells. So dose does matter, size does matter in this situation. So we want to try to find the highest tolerable dose. We want to find the highest dose that the patient can tolerate and function. We don't want to disrupt function. But for some patients, the healing process may occur while they're sleeping and resting. That's where healing takes place. And so sometimes if they need to sleep all day, at least in the beginning, once they get to an effective target and they have a bad cancer that is going to kill them, I will not discourage that dose and let the patient have extra sleep, even though they're lethargic and they don't have much of a life. If the cancer continues to grow, they're certainly not going to have much of a life either. So sometimes during that period of excessive lethargy in the early stages of the cannabinoid treatment, the patients may need to sleep more in order to allow the healing to take place. So this is a slide that Mara showed, and I have it in my slide deck just to simply show that one, as a general rule, the younger you are, the higher the dose that can be well tolerated and can be achieved and be effective. But as you get older, sometimes the patients can't tolerate nearly as much medicine. So it's not, and you can see, or maybe you can see at the top of each bar is the weight of the patient. So there doesn't seem to be any correlation between weight and the medicine. So you've probably heard mention of the software that Mara has been developing called CDR Med. I've had the privilege of using this software for the past over the past year, and it really provides a great service to physicians. I know it's going to be used not only by physicians but by patients and by dispensaries, but I'm very pleased with the use of this software. It does a number of things. One, if you see advanced search, I can put in the box above the advanced search, I can put in neuroblastoma, and I can see every patient that every patient for which this software has been used to organize the information for those patients. So I can get all the neuroblastoma patients, I can see what was used, I can see whether it worked or it didn't work, I can see what changes were made in the protocol that initially didn't work that then subsequently worked, and then not have to go through that ineffective period, make the transition early. So having a catalog of all the other patients with that same condition is very helpful. And so my data from the past year and a half is in CDR Med, and when it is available for other physicians to use, they will have the advantage of the road that I've paved in generating data and discovering what works and what doesn't work. The other thing that software will do is the drug interactions that I mentioned will automatically be determined by the software. You don't have to go to a Medscape drug interaction checker. Now, one of the interactions that most people are not aware of is that there are a number of drugs that are prodrugs. Now, prodrugs have no direct drug effect by themselves. They have to be converted from an inactive form to an active form in the liver in the cytochrome P450 system. In other words, it's the metabolite of that drug that is actually the effective molecules that do what you associate with that drug. Let me give you an example. So the estrogen blocker, God, I always block the name of this drug. The most common estrogen tamoxifen. Tamoxifen is a prodrug. So if you have estrogen positive breast cancer and you want to use cannabis to treat your cancer, and you're on tamoxifen to block the estrogen because you have estrogen positive breast cancer, and you use tamoxifen with the cannabis, you may not activate the tamoxifen because it can't, the blockage of the cytochrome P450 system by CBD to a greater extent and THC to a lesser extent may prevent the tamoxifen to be converted to the active component. So it's important to know about these drug interactions. You have to do the drug interaction check for every patient, for every drug they're taking, because there will be an influence by the cannabinoids. So the CDR Med software, among many other things, will automatically do that. So how to create the protocol. So you do your homework with the PubMed and Google Scholar searches, decide on the amount of total cannabinoids daily, and that's dependent upon the age and the diagnosis, the past experience with cannabis. So if somebody tells me that, you know, I tried even like 5 milligrams of THC in a piece of chocolate and it just makes me crazy, I can't do it, I know that this patient is not going to be able to easily get to 50 or even or 100 or so it would not be wise to prescribe and believe that they're going to be able to take 100 milligrams of THC when they can't even tolerate 5. The building up tolerance will maybe get me to 10 or 15 or 20, and maybe in 6 months they'll be able to get to 50, but it's going to be a long, slow road to hoe. So I haven't used that expression in a while. Anyway, so I would create the protocol, even though it might not be what I would think would be the best protocol. It might be the best protocol for that particular patient because of their past experience. So you have to use everything, all the information that's available in creating the protocol. Not to acknowledge that they don't tolerate THC would be a mistake, and then what would happen if I prescribed more THC than they could handle, from the get-go, they would stop using it. They would say, you know, I can't do it. I'm not going to do it. So I try to figure out what the patient's going to be able to use effectively, and then then you have to decide on the proportions. And so if it's an ID1, I'm going to use more CBD. If it's an HPV, I'm probably going to use considerably more CBD than THC. Maybe 1 to 3 or even 1 to 4 THC to CBD if it's an HPV. And as you can see, even among the tumor class of sarcoma, there are some sarcomas that the literature tells me respond better to THC than CBD, and other sarcomas which respond better to higher doses of CBD. So you have to know what the literature says to create your protocol. And then the way that I usually recommend that patients take the medicine is 10 to 25% of the THC first thing in the morning, and that way they may be able to go about their day without being so intoxicated that they can't function. And then 2 doses of CBD. The first dose of CBD follows the morning dose of THC by 2 to 3 hours. The second dose of CBD comes 2 to 3 hours after the first dose of CBD, and then the majority of the THC comes at bedtime, 75 to 90% of the THC at bedtime, preferably 30 to 40 minutes before they actually fall asleep. And that way, higher doses are tolerated at bedtime, and the patient is able to sleep through much of the intoxication. So most diseases need THC. Cannabis must be lab tested, and with the above information, doctors can guide patients more effectively. And that's my presentation. Thank you very much. I'll be happy to take your questions. Older than 85. And if you start low and go slow, if you get a good infused olive oil, you can start with 1 drop under the tongue of THC and 1 drop of CBD, and just go up a drop at a time and see how she responds. If and you have to tell me what your objective is in using the medicine. If it's to halt the growth of the tumor, it would be, then you would want to track that to see if you were being successful. So I want all of my patients to keep me posted on their response, on their results. So I want scans. I want to compare scans and know what I'm doing. So if what I'm doing isn't working,
the negative cells or the cancer cells. Am I understanding this correctly?
Not so much. Not exactly. The THC does activate the endocannabinoid system, but the CBD works independently of the THC. Actually, independent might not be the best choice of word. They work.
Cell suicide or the cell death. And that's the mechanism that the THC activates by the lock and key analogy of activating the CB1 receptors. It does not work the same way for CBD. Though it does have cancer-killing properties, it's a completely different mechanism of action.